Okay. So I will start thinking a little bit how does it feel like to live life without a sense of smell? And I don't know if some of you have experienced that, but especially lately since COVID, I heard many, many stories. And I just want to picture one that is one of Katie Boateng, who is the president and co-founder of the Smell and Taste Association of North America. So usually when we think about smell dysfunction, we might think of a person in of advanced age that slowly has a declining sense of smell. This is not the case of Katie. She was like an undergraduate. She was going about her day. One day she sits at the table. She starts like eating a tangerine and nothing. There's nothing, she cannot perceive the smells. She puts it in her mouth and things taste very different than what she expected. But, she had a cold. So she thought, okay, that happens in a couple of days. It's going to be fine. Those couple of days never passed. And so it's been, I think, 14 years right now. And Katie has completely lost her sense of smell and she became an acquired anosmia. And she started then talking about what it means for her not to have her sense of smell. Multiple times a day, as Professor Chen was mentioning, becomes complicated, like it's not pleasurable anymore. It's not fun to go out and have lunch or dinner with friends because, maybe it's summer, it's sticky and you're in Singapore and you smell and you cannot detect that. Or simply like the food that tastes like more like cardboard and you don't want to have that painful reminder over and over again. On top of that, she said, okay, well, things are not changing. My sense of smell is not coming back. I'm just going to go to a doctor and surely they're going to help me find either a cure or figure out what to do next. And then she got really surprised because the primary care provider didn't know what to do. It took her years, literally years, to be provided with a smell test that could confirm that she had completely lost her sense of smell. And then it took years after that to release the idea that olfactory training, which is repeated exposure to odors, could actually help her get her smell back. And so finally, when a doctor told her, it's been 10 years, it's likely not going to come back, that she said, I felt relief, finally. I didn't have to keep trying harder and harder as everyone else kept telling me. So you can see just from this story, which is one person, I could have a million more to tell you, that a lot of this, there's a lot of pain, there's a lot of changing in nutrition. People that tend to have not complete smell loss, but hyposmia, change the consumption of salt and sugar, including like trying to get higher concentration faster. And we all know that have detrimental effects for nutrition. So then I'm trying to think, okay, this could be an easy problem to solve in a way. What if we had a measurement of smell function that we all get submitted to? And then we can tailor strategies, or at least telling people that they're not crazy and this is a real thing, and that we know that people have nutritional changes or mental health issues related to that. And if it's not convincing enough because this seems like a low-level evidence or solution, it's not a cure, then what I'm saying is that we have now evidence that smell dysfunction is linked with 190 different health conditions. And all of us, if we live long enough, most likely are going to experience some form of smell dysfunction. And those who do, especially if we look at the elderly portion of the population, we do know that people that have greater smell dysfunction, so they have lower olfactory function, they tend to die earlier when measured at the 5 and 10-year mortality. They also tend to have higher rates of depression. They tend to have a higher rate of metabolic dysfunction and higher rates of neurodegenerative conditions. Seems something that we want to start to predict early if we can, even if we don't have a cure yet. There's no drug at the moment that can actually reverse smell dysfunction. So, and this seems to, when I talk to many healthcare providers, the sufficient reason not to gather data at this point. But I'm on a mission to change that, and I hope all of you guys are going to help me in this. So, question: have your doctor ever asked you to take a smell test? Because this crowd might have received the smell test because you were in a research lab. But is this crowd very special? I don't see hands risen, and so congratulations, you're like 99% of the population worldwide, because I asked this question to many different audiences. And most people never receive a smell test. I know for those of you who are wearing glasses that a doctor told you that you needed to get your eyes checked, but this doesn't happen for the nose. And given just what I told you about all of the health conditions related to smell dysfunction, it might seem something that we want to change. One of the reasons why I think it's harder to change, aside from the fact that we don't have a clear cure for this at the moment, that we have strategies to improve health and well-being of people with smell dysfunction, is the fact that we don't have a great awareness about what smell does in our life. So this is just one of the series of studies that I run, and Jonas Junge, a postdoc in my lab, has tested 1,100 people across 22 countries and asked questions, among which, like, if you had to give up one of your five senses, which one would that be? And more than 60% of people say the sense of smell. And this is a clear misattribution of how we think about eating. It's not taste the driver of a lot of the things we enjoy, it's actually smell. And if we talk about why smell is important, I think people, when I talk to them, it's really hard to have them verbalize. English doesn't have a good vocabulary for it, Italian not as well. Some Asian languages are a little more gifted in this respect, but we have a hard time identifying that this is an important thing. And when I talk to doctors and I talk about otolaryngologists, I thought I don't have to convince them that we need to measure the sense of smell, like they're trained specialty medical professionals in this day now. And then they tell me, well, you just need to ask people what their sense of smell is like, and they will answer. We just need a visual analog scale, and that would be enough to get a ballpark of what people perceive. And then I usually pull up this slide. So if we look at COVID, which is the time where arguably in the history of humankind, we have the best olfactory data ever, right? But just simply for the amount of people that were reporting it spontaneously or were subjected to some sort of a smell test. What we think is that when I focus on kids, which, the story goes that COVID does not affect the smell function in children. When we look at the meta-analytically to the data, and I'm looking at subjective evaluation, so just asking. Subjective here means I ask the kid, I ask the parent, or a doctor wrote something in the medical records. We don't know based on which evidence, but there's a somewhat record. Or psychophysical, I asked the kid to actually smell an odor of a standardized test or not. We don't want to get too precise here. But basically, we're underestimating by 45% the number of kids that have a smell dysfunction by using a subjective method. But then you say, well, kids, it's hard, and the younger kids don't really know how to answer questions about smell. This is just a problem that is for the younger population. These are the data for adults at 18 years and older. When you ask during COVID, what is the self-reported experience versus the psychophysical measurement, we're underestimating 1 in 3. So why is this happening? It's not that we don't have smell tests that have been validated, standardized, that we could use. The problem is, especially in the world with a COVID perspective in mind, where a smell test could have been a way to get people access to building, you cannot spend 10 minutes, 5 minutes, 15 minutes at the entrance of a door and having smelly pens or scratch and sniff that you drop, on the you drop on a bin, and then the environment gets all smelly. So the tests that we have are long, they are expensive. To give you an idea, the BC it costs, like this test, which is a 12-item test, it costs $19 US dollars. This costs like approximately $7, and this costs $220 when we're lucky, but it's hard to get one, so you usually pay more. You can clearly understand that we cannot get nowhere near the population level surveillance of olfactory function with these tests, even if they work. And when I go and reveal into the literature, what are the population level data of prevalence of olfactory dysfunction with whatever test across whatever country, the only constraint that I put is that we need to have at least 750 people, what I see is that the best data that we have are from the National Health and Nutritional Examination Survey in the US. If you wanted to guess when is the last year that we have that cohort data from, is 2014. We have not been able to get a measurement post-COVID yet because hearing is more important. But we can talk about that. I need to be faster. Okay. And Japan with a similar version of the same test as 16%. So there seems to be an idea that when we measure in a very specific set of people with the odor identification tests, which are biased because of language and cognitive issue, we get like 12 to 16% of the population with issues. COVID turned like millions of people into temporary holder or smell dysfunction, but this turns into 5 to 10% permanent. And this is true for Alpha and Delta variants, but it's also true for Omicron, although to a slightly lesser degree. But the counts goes up when we think about this at the level of the population. So that's why we devised with colleagues at Monell a new test that tried to solve all of the problems that I talked to you about. And this is called the Sentinel. It is a card, you can mail it, it has a triangle test. That is what we call the odor detection. The simple question is, where is the odor? Kids from age 7 can complete it without supervision, and the elderly can complete it without supervision too, even if it's you have a QR code that gets you to like a screen and a couple of questions. The second function that we measure is intensity, which we figured out from a survey during COVID that was extremely predictive, much more predictive, even if it is a subjective measure than odor identification. We include the odor identification, which we have kind of weighted down in terms of the effect that it has on the ability to determine if somebody is anosmic, hyposmic, parosmic, or normosmic. And then we asked a couple of questions on the pleasantness of the odor because we wanted to capture parosmia. And Sentinel, it is the first test that has a psychophysical component that can measure parosmia at this point. We don't have there is another test, but it doesn't work that well after the initial N equals 2 paper that was published. So what we did here is that Sentinel is at least 3 times faster, 2.5 times cheaper than all of the other tests, and it is self-administered. We have more than 5,000 data points across different populations from ages 7 upwards. But it is as good as one of the gold standard, if you will, which is the NIH toolbox, which has been developed for population level surveillance of cognitive, emotional, motor, and sensory function. And so with one odor and 4 questions, we got at the same result and for much less price than what we got to this standard. And at 95% of accuracy. These are 2 independent studies that replicate each other. When we compare exactly the type of information that Sentinel gives us in comparison to the other tests, we can see that it is as good as the NIH, the BSIT, and the sniffing stick. So once we start to have a more complex test, so 16 items versus 1, of course, we're going to have more misclassifications. But again, the number of people that can take a sniffing sticks identification test is much smaller than those that could take a Sentinel test. And we have 9 odor versions. So Sentinel comes in 1 odor at a time, but the versions are more or less equivalent. There are a couple of banana and coconut that are in for the American population that work as well. And we're able to actually see that when we look at broadly at some ancestry-related factors, the different versions of Sentinel can actually be equated. We don't have a large enough sample of Asian participants at this point, so I'm really curious to see what are the specific differences. Heritability is quite low, so we only know that there is a component of pleasantness that has some effect here. Otherwise, it's quite resistant to this test to specific anosmias. And the one that seems most problematic is only the odor banana. This is a study run on 1,000 twins and triplets. So we could actually tease apart the differences between monozygotic and dizygotic twins. We're taking Sentinel around the globe. So samples from the US, from Italy, from Nigeria, from China at this point, and we have 3 at least that are upcoming. The goal is trying to understand with the same odors, how do we craft different distractors, for instance, or what are the odor versions that we need to eliminate across the different countries to make sure that we have a test that can be used across the globe with the same accuracy. And my goal here is to really have an easy instrument that we could all use and put the data potentially in the same, so that we can really track the prevalence of olfactory dysfunction and use it for segmentation in different population groups. Of course, I'm thinking about health and then eating practices as well. So I'm going to go quickly, but acknowledging all of the people that are working on this, and hopefully there's going to be a larger group after this. Thank you for your patience with me being late, but it seems a leitmotif today.
No problem. Yeah, thank you very much, Valentina, for that. We have time for one quick question. If anyone has a question, otherwise I'll be forced to make something up. No.
We can talk about it later.
We can talk about. So if no one has, there we go. That's a good.
You have to test it.
Yes.
That's very subjective.
It is subjective, and we can, so what we asked for 2 questions about pleasantness. We're trying to measure the pleasantness range. So we ask people, this is the odor, how much do you like it? And it could be lemon, coffee, orange, strawberry, coconut, banana, whatever. And imagine the odor of vomit and tell me how much you like it. So we kind of standardize on the odor of vomit. I haven't found any weirdo that tells me that the odor of vomit is really, really good, which gives me some hope in humanity at a certain point. And it is true that people use the scale in a different way. So we're collecting a bulk of data to really try to monitor what 20 means on a scale from 0 to 100 here. What we do see, though, are 2 things. One, that vomit doesn't, it's at 20 at best. So we know that 20 down, which confirms previous data that we collected with the same methods during COVID, means that people really cannot smell or really don't like something. And I forgot my second thought that was brilliant, but you'll have to wait for that. It's gone. I'm sorry. So,
Thank you very much.
thank you.